Hi, everyone. My name is Audrey Vernick. I'm the Director of Educational Advocacy and Training for the Brain Recovery Project. And today I'm going to talk to you about comprehensive IEP evaluations. What assessments does my child need? This will be part one, and part two will be next week. So just so you know a little background about me, my son had a right hemispherectomy when he was 2 years old. He had intractable epilepsy, and he's 15 now, and he's enrolled in a small non-public school, and he's planning on going to college. It's quite a journey to get here, and so I've had a lot of personal experience with it, and then I've been working with the Brain Recovery Project. We launched our advocacy division in 2016. In an effort to support families navigating the IEP process for their children after epilepsy surgery. And we provide a biannual conference, guides, webinars, school training, and more. And there's a lot of information on our website. So hopefully you all watched a beginner's guide to IEPs after the epilepsy surgery. I'm going to only discuss step 2 today, which is assessment. If you haven't watched that presentation, I highly recommend it. So assessments are the foundation of the IEP. This is the way that we help determine appropriate services for the child. It's important that it's an accurate picture of all the child's needs, a comprehensive evaluation in all areas of suspected disability. And the IEP is only as strong as the assessments. The assessments are truly the foundational piece of the IEP. So what do you want the IEP team to know about your child? You need to tell them as part of the assessment process. Our kids are so rare. Children after epilepsy surgery are children that most educators have never worked with. And so we need to provide as much information as possible to help design the educational plan for the student. And we do this through comprehensive evaluation. I want to comment here too that the child does not need to be low performing to require special education and related services. So what we're looking at is really looking at all of the areas of need. It does not need to just be academic. So when you think about what you want your team to know about the child, just think about the questions you have about how your child learns. What are the issues or deficits that are getting in the way of access to curriculum for your child? Make a list of those key concerns for the assessment team. It can be presented as a parent concerns letter, even when you submit your request for assessment. Provide documentation to back up any concerns, like samples of homework or other outside doctor reports, etc. You can provide outside assessments. Those can be beneficial, especially if provided before the school district assessments are done. These requests for evaluation must be in writing. Everything should be in writing. We have template letters on our website under the guides and resources in the parent section of the IEP. So the purpose of the assessment process, this was discussed in our previous presentation. I just want to comment, we know the basics. It's to determine eligibility, to identify the child's needs for the special education related services, to determine those present levels. This is all to design an appropriate educational plan. I want to add a couple of things, which is that once the child is eligible for special education, they do not need to meet the same criteria in other eligibility categories in order to receive the related services, special education or related services. So if the IEP team determines that there is an area of need and that determination is made by that appropriate and comprehensive assessment, then that service can be provided and the eligibility criteria does not have to be met the same way as it would be if the child was entering special education in that area. And even sometimes I'll hear teams say, well, we don't need to list that label on the IEP because we know what we're going to be doing for your child. So while the eligibility is not critical, it can be important if you feel like it's adding a piece of information. If your district allows more than one eligibility to be listed, that can be important. So depending on the situation, you may want to ensure that an additional eligibility category is listed. And sometimes I'll hear school teams say that your child already qualifies for special education and we don't need to do any more evaluations. The problem is that what happens if things change? And kids who have complex medical issues, there are often changes that occur throughout the child's life, especially if there's additional surgeries or if there's a long absence or the child's seizures recur or medications change, that sort of thing. And just to have present levels, you definitely need to have evaluation and reevaluation as needed. And just because a child maybe isn't eligible at this time doesn't mean they will never be. So periodic reevaluation may be needed in areas that even they didn't meet criteria for services or eligibility in the past. One point I want to make is that most assessments out there, most standardized assessments and diagnostic assessments are not normed for kids with visual, auditory, or motor challenges. This doesn't mean that we don't do them, but we have to be very careful about how the results are interpreted and that multiple measures are used, which is a requirement anyway, but we really want to ensure that we're getting a complete picture of the child's needs and challenges as well as their strengths. Norm referenced instruments, which I'll explain in detail, which are diagnostic measures that are used on testing, may not provide the type of data needed to design meaningful interventions. They may be needed to establish eligibility, but they might not be helpful in designing IEP goals and services and really understanding children with more severe impairments who have these visual, auditory, and motor challenges. There are measures that can be used with nonverbal children with lower IQs, et cetera. So it's important to that the evaluator try to find the appropriate evaluation for the child and a variety of measures. So who's the expert in the child's condition? I know the moms out there are all saying, I'm the expert. And while you are, in the eyes of the IEP, we need those experts that are doing the assessments on the child to be determining what the child's needs are. So a doctor can diagnose your child, but the next step is to uncover the educational implications of the impairments. So the real question is the diagnosis having an adverse impact on the child's education, requiring special education and services? A diagnosis does not automatically trigger identification, nor does it qualify a child for an IEP. They have to also meet those other criteria, which we discussed. They require special education and one-related services. They're identified as a child with a disability. So to start the process and to paint the picture of who your child is and get the assessment process going, you can get a letter from the neurosurgeon or the child's neurologist before requesting the assessment. Provide the IEP team or your school district special education director a letter from the child's neurologist or neurosurgeon who's working with your child. This can help form the basis of your request for assessments. Now remember, the doctor can't prescribe services in the school setting, but they can explain, why did your child have surgery? That's the etiology. What was the procedure? They can list all the effects of the surgery. Different lobes of the brain being removed or disconnected have different effects. So for example, a temporal lobe would lead to an auditory impairment, occipital lobe resection would lead to a vision impairment, frontal lobe, motor impairment, et cetera. And we'll talk a little bit more about that. And then list all the suspected effects of the type of surgery your child had, so that it's specific to your child and it isn't a generic children who have X have these needs, but it's no, this child, John Smith, has these needs. We have a letter on our website that you can use as a template. So what assessments are needed for a child with a different brain? I'm going to outline the assessments that should be considered for any child after brain surgery in order to receive a comprehensive evaluation. This will vary greatly depending on the type of surgery your child had, the functioning of your child, and really what your concerns are. If you don't have many concerns, then you may need very few evaluations. If there are many, many areas in which your child is struggling, that need is going to be greater. I like this visual. It's actually from an occupational therapist, and at the bottom is the central nervous system, which is basically our brain. And then you look at how all these skills build above that. And if any one area is disrupted or affected, it can affect that top the pinnacle of academic learning, and I would call the pinnacle success. So this is used in the occupational therapy world to look at those tactile, vestibular, and proprioceptive foundational skills. But you can see how anywhere else along this, any of these areas being damaged or impaired may affect the child's ability to have successful academic learning. And after epilepsy surgery, there's a lot of possible challenges. So although every child is unique, some of these challenges are common, especially for children who've had a large resective or disconnective surgery. Things like difficulty with the mechanics of writing, a hearing or vision impairment, which would be central auditory processing disorder, hyperacusis, a homonymous hemianopia or quadrantanopia, visual processing or tracking issues. Difficulties with reading and writing, that can include spelling, reading fluency, critical thinking, specific challenges with math, organization challenges, which includes the executive function and attention and focus, the communication, social interactions, cognitive processing. This is the retention of information, working memory, cognitive overload, stamina to accomplish tasks, the rate at which a task is accomplished. Gross motor, so that's your mobility, your self-care, levels of independence, and then sensory issues. So these are some things that you might be thinking about when you're writing your letter of parent concerns. What are the difficulties my child is having that I would like an evaluator to look at more fully and see if these are areas that need support? So we have a recommendation of what the comprehensive educational evaluation after epilepsy surgery would look like. This would be for a child who had major resection or hemispherectomy, every single possible area that could be assessed. Your child, again, may be different. You might not need every area assessed. My son, for example, who had a hemispherectomy, has had every evaluation on here except for AAC and nursing. He's never needed a nurse at school. So depending on your child, you're going to look at what the right evaluations will be. And I'll talk about each of these in detail as we go throughout the presentation. The IDEA, which is the law that overrides the IEP process in special education to children with disabilities, states that the school system must ensure that the evaluation is sufficiently comprehensive to identify all of the child's special education and related services needs, whether or not commonly linked to the disability category in which the child has been classified. So there are many different types of brain surgery, and I don't know what each of your child's specific brain injuries and disabilities are, so that's up to you to research. And Monica Jones did a great job in the Beginner's Guide to IEPs presentation. She's really the expert in talking about the brain and its functions, so please listen to that. But one point I just want to make is that we know that if the auditory cortex is removed on one side in the temporal lobe, there's going to be an auditory processing disorder. We know if the occipital lobe is removed, there's going to be a vision impairment, etc. But what we have to think about is that all of these systems are connected and there are these networks. So really, if any area of the brain is damaged or impaired or removed, there can be wide-reaching effects. And that's what we really want to get to understanding with these comprehensive evaluations. So psychoeducational versus neuropsychological. I'm starting with this because this is the question I get the most. Do I need both? And my unequivocal answer, I feel, is yes. A child who's had epilepsy surgery, the neuropsychological evaluation is the most important, and any child who sees a neurologist should have a neuropsychological evaluation. You need an expert who understands the child's brain functioning, the cognitive processes associated with brain-based conditions. A neuropsychologist is knowledgeable about brain-based disorders, brain anatomy and function, and developmental issues. They understand the underlying neurological process causing symptoms, the why and the how, not just the what. So it's important to start out with a very good neuropsychological assessment in addition to the school district psychoeducational assessment. So while neuropsychologists may use many of the same tests used by school psychologists, they interpret the results in light of their special expertise in those brain behavior relationships. This report is your tool for understanding what that child's IEP should entail and how to teach him based on how his or her brain functions. So I will talk more about how you can obtain a neuropsychological evaluation. Insurance will often cover them. You can find a free or low-cost assessment clinic that are often overseen by excellent neuropsychologists through your children's hospital. However, the school is ultimately responsible to evaluate your child in all areas of suspected disability. So if your child has a neurological impairment, you should request a neuropsychological evaluation. I've discussed most of this already. It provides the most comprehensive picture, how the child's brain processes, etc. The neuropsychological evaluation will not only identify the needs of your child on a comprehensive level, but they also provide a thorough list of the direct classroom or indirect supports and services recommended for that support. Standard learning interventions may not work for a child with a neurological condition, and the piece that is often missing from many school district assessments, not all, but many, is recommendations, specific recommendations for interventions in each unique area. And that's where one of the key pieces of a neuropsychological evaluation.
Can I interrupt you just for a second?
Of course, please.
Just to say that the IDEA, and especially the regulations that go with the IDEA, say that the assessments must also include recommendations for the educational services that the child gets. So go to my training webinar, because it's not enough that they just identify the disabilities and needs that your child has, but they must also provide recommendations. It is not a valid evaluation if the school district's evaluations don't also provide recommendations for the interventions and services that your child needs.
That's an excellent point, and thank you for pointing that out. All right, so there's a lot of information in this presentation. I don't want to be overwhelming, but I'm trying to give you as much detail as possible about the different types of assessment measures that are used. Honestly, I didn't know what assessment measures were. I had never looked at them. I didn't know the names of any, and I'm sure most of you are in the same position where you don't know the difference between a California Verbal Learning Test and a Stanford Binet and a Wechsler Abbreviated Scale of Intelligence. I don't expect you to know that by the end of this presentation. I'm putting the names of all the assessments up so you can start to familiarize yourself with them. What I would recommend is that when your child is evaluated, ask the evaluator, what assessments do you plan to use and why? And then after the once you know what assessments they're going to use, either before or after, look up the assessments. Look and see what age level is that assessment for? What does it measure? And if you feel like all the assessments are measuring something that's not really valid to your concern, you might say to the evaluator, well, there's nothing here about pragmatic language, which is really my big concern. I see you looking a lot at cognitive function, but I want to make sure my child learns how to have friends. So this is a lot of information, but just take it as a way for you to start to familiarize yourself with it and for you to get familiar with these tests. So these are many measures that a neuropsychologist may use, and the assessment process would look like a parent interview. So again, you're going to have your list of concerns ahead of the assessment, just like you would for write a parent concerns letter for the IEP team. The evaluator will do a records review. They'll submit teacher and parent rating scales, and they'll do 4 to 8 hours of testing generally. And again, they're looking at all of these different areas of brain function, the cognitive processes, working memory, acquired knowledge, which is your achievement, your reading achievement, written language achievement. These will vary by age, of course. An older child would be assessed for reading achievement. A younger child would have different measures used. Executive function, attention and concentration, all the different areas of processing, auditory and visual processing, language functioning, and again, the sensory development, gross and fine motor, the social skills development, and then also emotional and personality development and behavior function is generally assessed by a neuropsychologist. These are some assessment measures that may be used for attention and executive functioning. Our kids may struggle with attention, working memory, and executive function skills, and these are major impact on reading and reading comprehension. So I'm highlighting this here, that this is a very important component. I don't want to generalize, but I would say most children who have epilepsy, period, regardless of epilepsy surgery, may have an impact to their attention and executive functioning because of the seizure medications. And then when you throw in a resection or some other major trauma to the brain, we often see deficits in these areas. So that attention is being able to sustain attention to tasks, persisting during tasks. Working memory is that ability to hold information while learning new information. Very important for learning how to read. And then executive functioning is that ability to self-monitor and guide your performance and not be distractible, basically. So these are some of the assessments that may be used. There are tests of attention working memory. There are tests of the Dallas-Kaplan looks at visual scanning, sequencing, switching, inhibition, which is holding back your desire to move around or look around. One point I want to make here is that central auditory processing disorder may present as ADHD. So I often see children who have an ADHD diagnosis who actually have a central auditory processing disorder, and they have not been properly evaluated. Doesn't mean you can't have both. So there are kids that have both, but we'll discuss that in part 2 of this presentation. Very important to recognize. So the psychoeducational assessment, this is the primary assessment that the school district offers. You'll see a lot of overlap with the neuropsych, and that's okay because the child's strengths and weaknesses are viewed from different angles. However, the psychoeducational evaluation alone would not be comprehensive for any child with a brain-based disorder. Hearing and vision tests are typically performed first to be certain that a deficit in one or both of these areas is not causing issues, but these look at acuity only, and I'll discuss that more when we talk about vision and hearing. So the purpose of the psychoeducational evaluation or psychoeducational assessment is to give information about the processes that affect learning, thinking, and behavior, to provide the basis for designing that educational plan. It's important in the prevention of educational, behavioral, and social emotional difficulties through early identification of the special needs of the student. The psychologist can assess for a specific learning disability, and they may determine eligibility for special education if their need for special education falls under their domain. If a child is visually impaired and or orthopedically impaired and has auditory processing disorder, a psychoeducational assessment may contribute to that, but they might not be deciding on the primary eligibility categories in this case. Intellectual disability it may not be assessed under specific learning disability, and many districts don't use IQ testing at all anymore, which I will discuss later. So oftentimes there are some diagnoses that need to be provided by your doctor and then brought to the school team. And then with autism and ADHD in children after epilepsy surgery, I just want to mention that we want to look at central auditory processing disorder for the ADHD diagnoses. For autism, there can be a link between cortical visual impairment and a misdiagnosis of autism. So when we get to the vision, I'll discuss that as well. But you want to make sure your child is properly diagnosed with all of the disabilities that they may be affected with. And that's why it's so important to have this comprehensive evaluation. So what does a school district psychoeducational assessment look like? So this is usually an interview and an observation by a school psychologist and written tests. And the written tests are standardized, which means they're administered the same for everyone and they're scored on a predefined scale. It's important that the children being compared have been exposed to the same level of education. So if the child has missed a substantial amount of school because of brain surgery or for whatever reasons, it might not be entirely appropriate to directly compare him or her to the same age peer group. It may include intelligence testing and cognitive assessments to get a better understanding of how the child's thinking processes work and what the strengths and weaknesses are as a learner. Looking at emotional and behavior concerns, the child's personality, moods, and temperament. What are the roles and behaviors in the family? What are the measures of adaptive functioning? This will result in a written report describing the child's current educational performance and identifying the precise instructional needs in the academic skills, language performance, and functional areas. So this, as Monica stated, there should be recommendations that identify these needs. Then the report will include any academic testing results, the classroom teacher narrative, and observation. A parent interview and parent concerns should definitely help shape this assessment process as well. This type of testing takes somewhere between 2 to 4 hours for the child, depending on which assessment measures are being used, and that often depends on age. The special education teacher will also conduct an assessment that looks at academic functioning with students to the same age. This is focused on reading, writing, math, oral language. It looks at several areas within each area. So for example, reading, which we're going to discuss at length, there should be a subtest measuring reading comprehension, recognizing sight words, the speed of reading, etc. This testing focuses on broad skills that a student should know rather than testing what's taught in class. So it's not a test you can study for. The school social worker may be involved to interview parents to obtain information regarding the student that's pertinent to eligibility. So they're looking at the child's developmental history, the adaptive behavior at home and school. Sometimes the social worker or a visiting teacher will visit the child at home. And for younger children, an early education, special education teacher might conduct a developmental assessment if the child is too young to be formally assessed with other measures. This is going to measure the basic skills such as early academic knowledge, the adaptive behavior, communication, and motor skills. And then other information that may be reviewed would be medical records. And of course, in the case of a child who's had epilepsy surgery, that information should be provided to the extent you feel comfortable, the information that you feel is pertinent to share. And you want to submit any written reports from a licensed physician indicating the medical history, the medical or health problems. That's where the letter from your neurologist or neurosurgeon can be helpful. And then there are hearing and vision screenings and outside evaluations. So there's this specific specialty area testing, I'm doing air quotes, which is that if there are concerns in other areas such as speech and language or occupational therapy, then there would be further evaluations done, and I will discuss that in the part 2. So here are some of the measures used by psychologists. Again, this is just for you to start getting familiar with the names. And like I said, if you see which assessment measures are being used, Google them. Go look and see what are they measuring. You need to understand the testing that's being done as best you can. Cognitive assessments will measure the student's general intellectual abilities. It'll show how well the child problem solves, how he interprets information, visual and auditory. It'll look at memory and processing speed. They often have an overall IQ score, which I'll talk about more. And then the social emotional assessment, adaptive behavior. It's going to look at the child's challenges, the parent concerns, the teacher's input, etc. So for a child with a more significant needs, and just so you know, borderline IQ is considered about 70 to 85, depending on your state. So intelligence tests would always be estimates because, like I mentioned before, those visual and orthopedic and auditory impairments may require accommodations that force them to break protocol. The evaluator must provide accommodations that the child requires, or the test may be invalid. However, some modifications can invalidate the test. So some of the tests that might be done for a child that has greater needs would be a comprehensive test of nonverbal intelligence. There's a Kaufman nonverbal scale. The lighter offers a completely nonverbal measure of intelligence and cognitive abilities. And the Wechsler has a scale for children that measures intellectual ability, and no literacy abilities are required. So depending on the child, again, you want to really be thoughtful about which assessments are used and why, and you need to understand that. So educational is part of the psychoeducational. As I mentioned, it's done by the school psychologist and the special education teacher. Looking at the current academic capability and performance. A school evaluation will not result in a diagnosis. So if you suspect something like ADHD, If the child has, other areas that would require a diagnosis, that would need to be provided by a doctor and submitted to the team. After receiving a diagnosis from the pediatrician or the neurologist or neurosurgeon, then that would help inform these evaluations. So I want to talk a little bit about formal versus informal assessments. This comes up sometimes when parents will say, well, the school district said my child is doing fine on their STAR assessment, or whatever the local or state assessment is. The child is doing fine. Or they did really great on, in class, like they're doing a great job on all their spelling tests or something like that. So as I mentioned before, in order for the evaluation to be comprehensive, it has to use a variety of measures. And for a formal evaluation, there have to be some formal diagnostic measures, particularly for eligibility. I would argue that formal diagnostic measures need to be used in reevaluation as well, so that you can have an apples to apples comparison from year to year. Sometimes I see different tests being used at each evaluation, and that can be very confusing. So those formal diagnostic measures are some of the measures I've already shown you on the previous slides. These are those norm referenced measures, and then a lot of other things may be used to help inform the overall assessment of the child. So the standardized test, that's state and local district testing, the curriculum-based measurement, any screening or benchmarking measures, and then the tests that show what your child knows in class. Those are the informal ones, and all the things that a teacher might see. So these are all part of the process, but on their own, not one of these can be a complete evaluation of the child. So here's an example of some different state assessments. They have their place, but they do not comprise a comprehensive evaluation. They're not diagnostic measures. They don't tell us anything about specific areas of weakness, and they don't provide recommendations for interventions and supports. Diagnostic educational assessment measures include the following. This would be part of that educational assessment that compares the student's academic functioning with other students their age. And I discussed this up above. So specific learning disability. So this is a term used in the Individuals with Disabilities in Education Act. You do not have to have a specific learning disability to have an IEP. However, about 50% of children with IEPs have a specific learning disability. It's as I've learned more about this, the term is broader than I initially thought. So we know about dyslexia, dysgraphia, which is writing, and dyscalculia, which is math, which is those are the most common specific learning disabilities. But it's a specific learning disability is a disorder in one or more of the basic psychological processes involved in understanding or using language, spoken or written, that may manifest itself in an imperfect ability to listen, think, speak, read, write, spell, or do mathematical calculations, including conditions such as those perceptual disabilities, brain injury, minimal brain dysfunction, dyslexia, and developmental aphasia. This was when IDEA was reauthorized in 2004, this was broadened to include some of the other components like listening and the perceptual disabilities and dyslexia. So what would that comprehensive assessment of a child with a learning disability include? So all of these areas, the oral expression, listening comprehension, written expression, basic reading skills, reading fluency, reading comprehension, mathematics calculation, and mathematics problem solving. So you're starting to see the complexity and the layers of testing and the numerous checklists you have to monitor. You have to see how robust and comprehensive your child's assessment could be. So the areas of processing deficit, like I said, we know about, in general, there's a lot of talk about dyslexia, the reading disorder, dyscalculia, and dysgraphia. But they're auditory processing, executive functioning, memory, processing speed, sensory processing, visual processing, aphasia, which is the limited ability to use or comprehend words, dyspraxia, which is a motor disorder that can also affect speech, but other areas of the body. Fluid reasoning is thinking and problem solving, and verbal reasoning and knowledge. Any of these would qualify a deficit in any of these areas as determined by proper evaluation could qualify a child as eligible for a specific learning disability. So I'm going to talk a little bit about the main ones. I'm not going to go into great detail about all of them. So dysgraphia is a learning disability that affects writing, which can manifest with difficulties in spelling, handwriting, and putting your thoughts on paper. Dysgraphia requires a complex set of motor and information processing skills. So again, when we go back to that image of the brain and the different areas of the brain that might have been affected, and the thought about networks and how if one piece is missing and now that network is disrupted, when you think about a complex set of motor and information processing skills, you can understand why there might be impairments in some of these areas. So again, we want to really be looking at every area of possible impairment. So you're looking here at what can your child write? Only his name? Do they have difficulty with writing numbers and letters? How do they write? Are they writing messy? Are they writing big letters? If the motor strip was affected, the fine motor function may be affected both in the weaker hand, but also in the dominant hand. Some of the assessment measures of writing include these standardized assessments that might be done by the psychologist, the education teacher, an occupational therapist, speech and language therapist might all be contributing to this type of assessment. I think a developmental test of visual perception would be important in looking at dysgraphia, because it uncovers how the child is processing visual information. And oftentimes children who have difficulty writing, it's not just a motor issue, there's a brain-based issue with processing that visual information. Dyscalculia is basically a dyslexia, math dyslexia, it's often referred to, although it's a little bit different. Kids with dyscalculia can often memorize, but they have a difficulty building the number sense that's essential to math learning. And some of the difficulties are common arithmetic tasks and number sense, reading analog clocks, stating which of two numbers is larger, and holding numbers in mind while doing math problems with multiple steps. We talked about that earlier, that's that working memory piece. So some of the assessment measures for math and dyscalculia will look at various skills, including the computation and problem-solving skills, which is what's required by IDEA, that the child is assessed in those two areas. We're going to look at the computation includes addition, subtraction, multiplication, division, but also fractions, decimals, percentage, oral or written math problems. How do they interpret graphs, complete patterns? And then advanced calculations like algebra, geometry, and calculus for an older child. Numerical operations, which is, counting, understanding numbers. Mental computation, the child's ability to do math problems in their head. It's also known as mental math. Quantitative reasoning or math reasoning, your child's math problem-solving skills. It's the ability to understand the quantitative relationships and set up a word problem, for example. And then practical applications. Can they tell time, work with money, measure length, volume, area, etc.? So here are some of the tests that would measure all of these various areas of dyscalculia. And then dyslexia. So most of us have heard the term dyslexia. The primary difficulties are decoding and recognizing words and non-words, accuracy and fluency, which leads to inaccurate oral reading, the sounds of phonology, reading comprehension, rapid naming, detecting rhyming words, and spelling. And all of these contribute to an overall reduced reading experience. So we're going to take some time right now and just dive into reading. So I want to tell you about this term, the diagnostic reading assessment. This is from IDEA. This is required. It's an assessment that is valid, reliable, and based on the scientifically based reading research. It's to ensure that the child has learned to read by the end of grade 3, and it's helping determine the possible reading intervention strategies. This is important because we've worked with researchers at the Brain Recovery Project who've determined that just because a child had a left hemispherectomy from stroke, for example, we can't draw broad generalizations about the outcome of a child based on the side of their surgery or the type of their surgery. The research showed how differently each child learned. And because they may have individual strengths and weaknesses, each child has to have those individualized, comprehensive assessments that analyze their individual strengths and are used to generate those intervention strategies. There may be variability even under children with the same underlying conditions. So we really need to support that flexible literacy instruction and the standardized assessments that analyze those individual strengths. And I'm going to talk next about the 5 essential components of reading. So in the previous slide, you saw that the diagnostic reading assessment has to be based on reading research, and the reading research shows that a comprehensive assessment should include the essential components of reading, which are phonemic awareness, phonics, vocabulary, reading fluency, which includes oral reading skills, and reading comprehension. So the big 5. This was discussed in our previous presentation. I can't underscore the importance of this enough. You must understand the 5 components of reading. You must become an expert in reading. If your child has any reading difficulty, if your child had cancer, you'd become a cancer expert. If your child is not a proficient reader, you must understand reading. So I recommend going back to our previous presentation and review our Reading After Epilepsy Surgery Guide, Part 1, which is understanding the big 5 for the early or struggling reader after epilepsy surgery, which can be found on our website. I'll just quickly remind you that phonemic awareness, which is sometimes referred to as phonological awareness, is the ability to hear and manipulate those individual sounds or phonemes in spoken words. This is why your child needs a central auditory processing evaluation if they have any deficit to the temporal lobe, corpus callosum, if they've had a hemispherectomy, etc., because they have to be able to understand the phonemes in words to begin to put them into the context of reading. Phonics is the relationship between letters and sounds. It's visual. It's important in decoding. Oh, I'm sorry. Fluency is how fast you read. This is important because it's the ability to read quickly and with intonation, with drama, with flair. This can be affected with children who have dysarthria or motor planning issues. They might read very slowly or inaccurately. Their prosody might be poor. So fluency can be important, but it could be challenging for certain children. Vocabulary is the words students must know to communicate effectively. It is possible for students to read completely phonetically and not comprehend what they've read because they don't have the vocabulary. And then text comprehension is understanding what is read. If you don't understand what you're reading, you're technically functionally illiterate. So that's the all-encompassing final, the reason we learn to read is for that reading comprehension. So the simple view of reading says that decoding plus language comprehension equals that reading comprehension. Good readers use all of these things that we just discussed in order to read. It's the fluent execution and coordination of word recognition and text comprehension. So what assessments are needed to evaluate in these big 5? I'm going to go a little quickly here because there's a lot of evaluations that could be used. Again, I'm just trying to introduce you to some of these tests to familiarize yourself. Just remember that the reading subtests of the Woodcock-Johnson or the Wyatt do not in themselves constitute a reading evaluation. State or local district assessments do not constitute a reading evaluation. And it's important to identify the reading difficulty as early as possible so the child can be provided with the proper type of supportive services. The earlier, the better, and then classroom and school accommodations, etc. So the different types of assessments are, we want to know what literacy skills a student has mastered. We want to monitor their response to intervention. We want to provide data that informs instruction, and we want to provide teachers with information on how to improve their instruction. Some of this was also discussed in the Beginner's Guide to Building the IEP. The considerations are that every assessment won't be appropriate for all students, and different measures provide different information. So the assessment has to be relevant to the purpose of the evaluation. If you are determining eligibility, it'll be different than if you're just trying to see if the intervention the school is using is working. For diagnostic assessments of reading, here are some measures for phonemic awareness, which is, again, the ability to hear and manipulate sounds and words. We rely heavily on our phonological memory when reading and spelling. These are assessments that would examine a student's knowledge of how sounds make words. And the phonological processing is comprised of phonological awareness, phonological memory, and rapid automized naming. So these tests, if you look through them, you might see some of those terms used as what they measure. So the CTOP, for example, the Comprehensive Test of Phonological Processing, they look to see if the child has difficulty with phonological analysis, and it includes a fluency score as well. So a number of different assessments there. Phonics is the ability to associate sounds with letters, or the process of using letter-sound correspondences to recognize words. An example of an assessment of decoding skills is to give the student words and ask them to read each word aloud. So that would be an assessment of phonics. For younger children, the assessor might present the child with a list of letters and ask them to name each letter. They might have them separate letters from a pile of letters, numbers, and symbols to categorize them, or categorize them by upper and lowercase. Just a note here that decoding, which is part of phonics, and language comprehension skills you can separate them for both assessment and teaching, but remember they're both required to achieve that reading comprehension. Okay, and so this is just a list of some of the assessments. And then fluency, this is the automatic ability to read words in connected text. The most common example of an assessment for fluency is just to ask a student to read a passage aloud for a minute. The words that are skipped or pronounced incorrectly are not counted. And the number of correct words read is counted, and that's why the total score equals the oral reading fluency. However, this type of assessment doesn't tell us why the student's fluency rate is low, and this is the most common kind of benchmark measure that's used in school with classroom teachers. So again, we go back to why we want that comprehensive reading assessment, so we can really understand which particular areas are we breaking down in the reading ability. So for example, the test of word reading efficiency looks at word reading accuracy and fluency. Rapid automized naming looks at letters, numbers, colors, and objects. And the scores are based on the amount of time required to name all the items, on each test. But we want to be aware here of processing speed difficulties. So again, each of these measures, you have to really consider what are the impairments that might be getting in the way of an accurate assessment. Vocabulary, that's really important. It can be a predictor of future reading disability. This has been highlighted in some of our research. Here are a number of different vocabulary tests. There are words that assess single word vocabulary abilities, and then going up into high school level assessments that are looking at syntactical and thematic maturity and word usage and style and sentences, et cetera, such as the test of written language, which is for 8 to 18-year-olds, basically. Here are some assessment measures for comprehension, which includes reading and listening comprehension. Again, this is the process of understanding the meaning of text. And I spoke about this before, but decoding and language skills can be separated for both assessment and teaching, but both are required to achieve that reading comprehension. So the way you measure reading comprehension is you ask the student to read a passage that's at the appropriate level and have the student answer questions about the text. You could ask the student to answer inferential questions about implied information in the text to measure inferential skills. Ask them to fill in missing words from a passage. Ask them to retell a story in their own words. So these are some of the tasks that they might do on some of these different assessments. This is just a list of some common standardized reading assessments. These are measures given to all students in the school to assess reading, comprehension, math skills, etc. So Ames Web and Dibbles, there's Fontes and Pinnell. There's a lot of common reading assessments. You may have heard these batted around. Remember, these do not constitute a reading evaluation. This is looking for benchmarking and progress monitoring and more looking at how is instruction going. I think of these as kind of measures for the teacher. If the entire class is doing very poorly on the Ames Web or the F&P, then maybe the material needs to be covered again. It can highlight areas of need for an individual student, but it's not sufficient for a comprehensive evaluation. In these types of the benchmark measurements, what's measured is the fluency rate. So again, that's how many words per minute they read. The accuracy rate, which is how many words they read correctly. It's important to note that their independent reading level is generally 94% and above. It'll depend on which specific tool they're using, Ames Web versus Fontes and Pinnell, et cetera. So you need to know the tool. Again, you can just Google it and find out what the accuracy rate is. You want to find out what the child's instructional reading level is and what their frustration level is. Below 90% accuracy means that it's their frustration level and it's not an appropriate reading level. And then their expression, again, prosody, do they pause at commas, stop at periods, change their tone for a question mark? And again, that oral reading fluency could be low due to speech apraxia and dysarthria. So if that's a concern for the student, it's important that they're measured using other tools. I see that it's almost 11, and I know we started a little late, so I'm wondering if we can go over about 10 more minutes. I'm asking Monica, and hopefully she will respond, but I'm going to keep going till I hear back from her. This is a comparison chart for reading levels. I'm pointing out the Lexile level. That's a nice benchmark to have, and you can compare it to whatever reading level your child might be, such as F&P. For example, if the child is level D, F&P in kindergarten, that's not a problem, but if they're still level D at the end of second grade, you can see that that would be a problem. You want to get a comparison chart or a correlation chart. You can find these online. So putting it all together, reading involves many skills. If your child has visual or auditory challenges, they'll most likely struggle with some aspect of reading because we have to decode. There's language comprehension, auditory discrimination, visual tracking, visual processing, attention, thinking, problem solving, working memory, and there's probably more that I haven't listed here that's involved in reading. So we need to assess those literacy skills by looking at all of the areas that were looked at in those neuropsych and psychoeducational assessments and the educational assessment, and then probably visual, auditory, and motor assessments as well. Again, I've mentioned this, the comprehensive assessment of students requires the use of multiple data sources. The evaluation should consist of many different assessments. You cannot make a valid judge of a student's ability with one measure. All that shows is what the student did on that assessment, on that day, at that time. So multiple data sources, multiple assessment dates, multiple assessment types. I'm going to briefly discuss the discrepancy model. I have about 5 minutes more here to wrap this up. So the IQ achievement discrepancy model is the traditional method used to determine if a student has a learning disability and needs special education services. It compares the assessment of a child's intellectual ability or IQ with how much progress he's making in school, which is academic achievement, generally a 15 standard score point gap between a child's intelligence level and reading level, for example. When there's a difference like this, it's believed that that indicates there's an underlying condition that is making this unusually hard for the child to learn. The discrepancy model was part of the original IDEA in 1975, and it was created so that schools would have a way to figure out which students were eligible for special education. In 2004, when IDEA was reauthorized, that changed. The law now says that states can use the discrepancy model if they choose. It also allows them to use other models. 39 states still allow their school districts to use the discrepancy model. 11 states forbid its use. Even within states that allow the discrepancy model, some districts forbid the use and flat out refuse to do any IQ testing. And this is sometimes due to racial and other biases in the IQ testing. There are some criticisms of the discrepancy model. Many parents and educators feel that a discrepancy model promotes a wait to fail approach, meaning that intervention comes too late to be meaningful, and it doesn't take into account all the factors that may affect a child's academic achievement. So we need to look at the absence or presence of a phonological component of dyslexia, and we need to detect those subtle neurological variations such as organization, attention, poor memory and retrieval skills, the dyspraxias and dysphasias. In other words, a discrepancy model would be too simplistic. Some schools will offer response to intervention as an alternative. However, for a child who's had brain surgery for epilepsy, if you have concerns, actually for any child, the child does not need to go through the response to intervention process first in order to be evaluated for an IEP. So reading in low IQ. The IQ tells us how much a student knows within the range of a developmentally typical intelligence, but it tells us very little about how well a child will respond to intervention. Many children after epilepsy surgery may have intellectual disability, but this doesn't mean they can't learn how to read. This notion is outdated. It's been extinguished by decades of research in the Downs, Fragile X, and Williams syndromes, as well as other communities of intellectual disability. Intelligence may be a predictor of school success, but it's not a predictor of successful reading. I often hear that the student's IQ is too low to read phonetically. At best, they can memorize sight words. So while IQ and other measures of cognitive functioning might correlate well with reading and mathematics achievement, they correlate poorly with student response to intervention. Baseline measures of reading comprehension are much better predictors at how the child will respond to an intervention. So you want to assess the underlying cognitive abilities to determine appropriate academic interventions, but a sample of oral reading fluency and accuracy could suggest the need for repeated reading or decoding interventions, for example. So to assess a child with a lower IQ, again, that borderline IQ is considered 70 to 85, and many of our kids after epilepsy surgery have IQs far lower than 70. We may need to adapt or modify existing assessments. Modifications might need to be used. Specific measures need to be chosen that would be appropriate. We have to be aware of the fact that many literacy assessments are dependent on verbal responses. That can be challenging for many kids who are nonverbal. Processing speed, the assessments of fluency, comprehension, and letter naming are all timed. So, they'll often see how quickly a child can respond in 3 minutes, and then they rely heavily on working memory. So again, we need to be aware of the deficits and choose the appropriate assessments. And then what about pre-literacy? I often hear the child is too young to be assessed for that. There are pre-literacy measures for children as young as 2. Waiting until middle school to find out your child has a reading deficit is too late. If your child has not cracked the reading code by 3rd grade, it's an emergency. So here are just a few. I have actually a list of about 20 early literacy measures that can be given to a child starting at age 1.8. So that's 1 year, 8 months. Generally, they start at about age 2 or 3. So last slide, why do we focus on reading? Reading is one of those skills that may define the future life and the degree of independence of a child. By the 4th or 5th grade, education generally shifts away from concrete to the abstract. This can be a major obstacle for any child with brain damage. Reading becomes about what one knows about the world, and the amount of what's written between the lines increases exponentially. So in our kids, the ability to get the big picture may be compromised, from spatial to critical thinking. Comprehension can be a challenge regardless of the type of resection. Some of our kids can read, but they don't understand what they're reading, especially as they get into middle and high school. So reading to learn subject matter becomes problematic. The epilepsy research shows that the kids with epilepsy often have trouble with reading. A low percentage of children after hemispherectomy, for example, have adequate reading skills. Our big concern in the Brain Recovery Project is that very few of these kids receive intensive intervention, and that the schools and possibly the parents don't understand the effect of the vision and auditory challenges on reading. So next week for part 2, we'll dive into all of the other assessment areas, and it all sort of circles back to reading as this foundational piece of education. And we do offer resources for the school team, many of which are available on our website. And you can contact me if you have further questions. Thank you for your time.